Hi, I'm Dr. Scott Worden, the TOS guy. Welcome to the second in our series of educational live streaming. About 15 to 18 years ago, I had the pleasure of meeting Peter Edgelow, a very famous physical therapist who had developed a very unique technique for treating patients with Thoracic Outlet Syndrome. Peter is no longer with us, but his mentee is. Steve Talajkowski is a highly accomplished physical therapist with so many letters after his name, I can't keep track of them. But he has carried on the Edgelow technique. He has tremendous experience with TOS patients, and I've had the distinct pleasure of working with him for more than a decade and watching his success with these patients. So I'd like to introduce Steve Talajkowski.
Hello, thanks for having me here. I could not hear what Scott said, having a little technical difficulties, so I'm just kind of winging it here, but I do have a presentation. I'm a physical therapist. I've been one for 27 years. I work in Hayward, California. About 22 years ago, I went to a clinic in Hayward now it's called Select Physical Therapy, and I started to work with Peter Edgelow. And Peter Edgelow is kind of well known in treating thoracic outlet syndrome. I worked with Peter for 14 years until he retired. And after he retired, I kind of took over most of those thoracic outlet patients myself. I use Peter's program. It's called the ENVEST program. It's the Edgelow Neurovascular Entrapment Syndrome Treatment Program. Sometimes it's also been called the Edgelow Neurovascular Self-Treatment Program. I use that to treat my patients with thoracic outlet syndrome. Here's a picture of Peter. He passed away in July 2 years ago. He's a great guy, great mentor, just a very generous, kind person. So here's some of what I've learned. Many of those with TOS or thoracic outlet syndrome have had the condition for quite some time. They've tried a number of different treatments and often with limited success. For many, it's hard to find the proper medical care or get an accurate diagnosis. That's a problem, especially if you're a work comp patient and you're trying to get your case covered or get treatment for it. And many medical professionals do not have a good understanding of TOS and in some cases still doubt its existence. People often lack significant findings on MRIs or nerve conduction studies, x-rays that could explain their condition, or they may have other conditions that coexist with TOS, making treatment more complex. So I wanted to share a few of the things that I sort of learned from patients. This is going to be a more personal talk. I'm going to talk about treatment and some of the things that I do as a physical therapist when a person comes sees me. But I also want to talk about what some people tell me. A lot of patients come in and say, my doctor does not believe in thoracic outlet. They might believe in it, but they don't know how to treat it, so they're not sure what to do themselves. People ask, will I get better? Or do I need surgery? Or have you heard of anyone else having these problems? And no one's really listening to me. I think the problem with all these questions is that people feel alone and that they're not really sure what to do next. They kind of doubt their symptoms, people doubt them. And I think it's a very kind of lonely, sort of out of control feeling. So I'm here to kind of help with that. So what I've learned too is that most people with thoracic outlet can improve if given the right treatment plan. But that right treatment plan often requires a group of people, multiple like professionals, physicians, physical therapists, nurses, acupuncturists, counselors, other holistic health providers, attorneys, and case managers. It's a multidisciplinary approach. No one can do it by themselves, not one person, either the patient or one doctor or therapist. What I also learned is a person with TOS must be their own advocate. You need to understand what it is and what can be done, because they're often leading the way to get treatment. And once they get a proper treatment plan, they must commit to that program. The right program takes time, It involves most every aspect of one's life. The treatment is holistic. It's not one thing, it's many things. So I'm going to talk a little bit about what I do when people come in to see me. I want to talk about the initial evaluation and the focus of treatment, and also some principles of the ENVEST program. I'm not going to talk about specific exercises today, because I think there's too many variables in treatment. But I'm going to give you some principles about how to treat, or what you would do to treat yourself, and how to start an exercise program. And if you guys remember last time, Scott was talking about posture, so I'm going to mention a few things about that. But I believe I have some more presentations coming up, and we'll talk more about that in detail in the future. So when I see a person initially, I'm looking to get a detailed injury, a history of the injury. Most people have a gradual onset. Sometimes it's not very specific, but it's kind of often related to sustained and repetitive upper extremity use. That usually means computer use, but it can mean something else, like in a warehouse or some production type jobs. In some cases, the onset can be a result of trauma or an injury, like a car accident or a sports injury. In the case of some younger people, they may not have a significant history. And we're talking about people, even middle school kids. They're playing sports, soccer, swimming, baseball, volleyball, and they just start to have symptoms for no reason at all. I also ask about the location and description of symptoms to get very specific. So I want to look at not just like where it is. Is it in the inside of the arm, the outside of the arm, the neck, the back, what side? And what do you feel? Numbness, tingling, burning, symptoms like that. Also want to know what activities aggravate symptoms and what eases symptoms. Things like computer use, driving, simple things, even just like combing your hair, putting on lotion, brushing your teeth. All those things are things that aggravate people with TOS. I also want to know how easy it is to aggravate and calm down symptoms. Irritability. That's crucial in kind of understanding not only on that first day of how to examine somebody, because the worst thing you could do is make somebody worse in your examination, but just trying to figure out how the treatment plan is going to progress and how quickly we can progress their exercise program. I've shown a couple pain diagrams. If you look on the one on the left, there's a person with pain going down their arm, kind of on the inside of the elbow side of the hand and going to the pinky. On the right side is a different pain diagram. The pain's kind of going down the arm. It's kind of not specific very well, but it's also into the shoulder blade. The reason I show these two pictures is that they're actually two different conditions. The right side is more of a cervical problem. This is out of a book, Treat Your Own Neck. The left side is more of a typical thoracic outlet presentation. And you can see how important it is to kind of decide what your pain distribution is. And in some cases, you're going to have patients that have both those symptoms on the scapula of the arm and then on the inside of the arm to the pinky. And like in that case, this might be a patient that has more than one problem. And we're going to get to that a little bit later. So when I'm doing the initial evaluation and assessment, I'm looking at objectives. These are things that you can measure. I'm looking at shoulder range of motion, cervical or neck range of motion, hand temperature. We do strength tests, the thumb and grip strength. We can get into that later. I'm looking at upper nerve mobility and sensitivity tests. If anybody's been to therapy, it's those nerve gliding or flossing exercises. Looking at venous drainage of the hand just to see how the blood flow flows out of the hand when you raise the arm. We can look at O2 diffusion with using a pulse oximeter. We can palpate the tunnels. I'm going to get into that later today. And also, if you need to do special tests to look at the neck, the low back, and the shoulder to see if there's other coexisting problems. So when you're looking at all the objective information and the subjective information, you're looking at the assessment then. You're building a case. You're looking for objective signs that support nerve or vascular entrapment. You're looking for signs of how much movement can be tolerated. I mentioned that earlier. The level of irritability and sensitivity. That's critical because if too much movement will aggravate the patient. So we need to find out what a person can tolerate. I'm looking for anatomical locations of the entrapment. If you saw Scott's talk earlier, he mentioned the scalene triangle, the costoclavicular space, the pectoralis minor. Those are all places that can be involved in the nerve entrapment. And I'm talking mostly today about nerve or neurogenic thoracic outlet. We do see some vascular, but primarily I see the neurogenic form. Not to say there's not a vascular component, there often is, but it's primarily nerve. We're also looking for secondary conditions, cervical disc, nerve root, lumbar thoracic spine conditions, shoulder impingement, rotator cuff, other peripheral entrapments such as carpal tunnel and cubital tunnel, because all those problems are going to affect or decide how we're going to treat or progress the program. And in some cases, those conditions could be just as prevalent as thoracic outlet. In other cases, they might be small problems, but there's still a problem that needs to be addressed. What I need to do then is educate the person on what the findings mean. While things are common among people with thoracic outlet, each person is unique for the reason I mentioned earlier. There can be more things than just thoracic outlet present in a case. If present, you want to confirm that the findings support the presence of thoracic outlet, but also realize or recognize the impact of other conditions. Also, I want to explain that there are effective treatments, but also that treatment's not a formula, and it will take trial and error. So in a lot of cases, just because I know how to treat a person with thoracic outlet doesn't mean that I know every step of the way what's going to happen next. It depends on the person, the pre-existing conditions, how quickly someone progresses, and just a bunch of different factors. Also, I need to give a realistic timeline on how long the condition can take to improve and what to expect during recovery. I don't promise someone that's going to get 100% better, but I can almost promise everybody that they'll see improvement. I'm not sure how well you can see this picture, but it's a picture of tunnels. Tunnels are where the nerves travel through to get to where they're going. If you look at this picture, there's a number of tunnels starting at the neck. So if you look at number one, that's the cervical spine. That's the central canal. That's where your spinal cord goes down. It's a spot where things can be compressed. Number two would be where the nerve root goes out of the spine. Again, pinched nerve, bone spur, things that can happen at the neck. I'm going to skip 3, 4, and 5 for right now because that's where we're going to talk about the thoracic outlet in a minute. But also 6 and 7, those are the peripheral entrapment spots. The ulnar nerve, the cubital tunnel, the carpal tunnel. As you can see, there's a lot of places that a nerve can get entrapped. It can get entrapped in more than one place. If we're looking at the cone again, number 3, 4, and 5, if you remember Scott's talk earlier, 3 would be the scalene triangle. 4 would be that costoclavicular space, and 5 is the pec minor. What's interesting here, I think, is that there's more than one place where the nerve can be entrapped, and sometimes it can be entrapped in more than one place. So imagine what happens if someone has a cervical nerve impingement, something happening at the scalene triangle and the pec minor, and also maybe a cubital or a carpal tunnel. You can see how it's hard to treat this, and it's difficult for one person, especially a specialist who might only specialize in one of those areas, to help you. So what we need to do is identify if there's more than one place, what to do. And then that's the part where we need to involve usually more than one person to help. I'm going to explain the ENVEST program again. And the ENVEST program may be different from other treatment plans. I've seen patients who've seen a number of therapists, and a lot of times they might come in and wonder why they're seeing me, because they've done a lot of things. And I'm almost always can guarantee that with the ENVEST program, we're going to cover something that they haven't covered before. One of the biggest plans is this is not a no pain, no gain program. Aggravating the condition will aggravate the condition. You got to make sure to calm things down. There is a time for strengthening, but now is not the time. This is a nerve injury. It's not a muscle injury. It's not a strength problem. It's not a tightness problem. It's a nerve injury. So my mantra is relax the muscles, open the space, and calm down the nerve. In Peter's program, he uses the ABCs. Peter liked to use sort of common words or phrases to kind of explain his program. So in the ABCs, we have A stands for activate the core, B stands for breathe, and C stands for cardio. I'm going to get into more detail in a minute. If you think about activating the core, what we're really talking about is posture. So a lot of patients that we work with have sitting jobs where they're at a computer and posture is an issue. So when we activate the core, it's not just to strengthen the abdominals or the glutes. There's plenty of people who have strong abdominals and glutes. It doesn't mean they have good posture. So we're using the core to help support the posture. Breathing is really awareness and stress management. If people have taken yoga, meditation, martial arts, forms of other sports, or maybe singing music, they realize that the breath is critical. Breathing in those disciplines is about awareness. It's about being in the moment. It's also about calming one down. If someone's stressed, a common thing you would say is take a deep breath. So breathing is a critical part of the ENVEST program. And cardio is movement. So it could be walking, but it could be running. It could be a number of exercises. But if you look at people that are sitting at a desk all day, these three things, posture, breathing, movement, usually are lacking. So we need to change that approach and get those principles into the program. If you look at the picture I have up now, you saw something similar with Scott's talk a couple of weeks back. I'm going to show you the scalene triangle. So you see two muscles or three muscles on the left side. You have a muscle in the front, that's the anterior scalene. You have a muscle kind of in the middle, that's the middle scalene. And then you have the posterior scalene. And if you look between the anterior and medial scalene, that's the brachial plexus. And then also the artery, subclavian artery. If you look at what the muscles are attached to, they're attached to the neck and the rib. So muscles can only do one thing or two things. They can contract or relax. So when a muscle contracts, it moves whatever it's attached to. In this case, since the scalene is attached to the neck and the rib, it moves the neck or the rib. So if you're going to look down and you contract both scalenes, you're going to flex your neck forward. But also, it can elevate the rib. Now you might ask, well, why would I elevate the rib? Well, the scalenes, besides being a neck mover, also are accessory breathing muscles. So if a person breathes from their upper chest, they're activating the anterior and middle scalene, and even the posterior scalene. If you look at the pectoralis minor muscle, the same thing happens here. There's not a nerve running through that picture, but that same bundle of nerves, that brachial plexus and the vascular components, are running through that space. Again, the pectoralis minor muscles attached to the ribs and the scapula. So that muscle pulls the scapula forward and over, but it can also elevate the ribs. Again, pectoralis minor muscles are accessory breathing muscles. These muscles are not meant to be used all the time. If a person's in a slouch position, which I believe I have a picture of that. Now there's a lot going on here, but you can imagine what's happening with the spine, the tunnels I talked about earlier, that central canal, that's the foraminal openings where the nerve roots come out of the neck, but also the scalene triangle, the pec minor. All those things are being compressed in this position. Also, if we talk about accessory breathing, muscle breathing, and we talk about diaphragm breathing, what we'll get into later, you can see in this position, it's really difficult to use your diaphragm, and most people are using their upper chest muscles. So besides compressing it by bending forward, you're also compressing it by tightening the pec minor and the scalene muscles. So what I'm getting to right here is that there's a lot of ways to go with treatment. You can go right or left or down the middle, but you have to go the right way. So a lot of people have gone the wrong way. And if you have to go right, you need to go right. So what I'm saying is that the people that are involved in your treatment plan need to be the right people. And that includes so many different people. This is a physician, the primary physician, specialists like neurology, radiologist, pain management surgeon, obviously the physical therapist. There's soft tissue, myofascial release, deep tissue, acupuncture, chiropractors, other providers such as yoga, meditation, counseling, Pilates, Feldenkrais. All these people can be part of your getting better, but they have to go down the right path. And it's sort of like this picture. Which way do you go? It's hard to know, but if you have a good guide, if you have people that know and understand the problem, you can get through that mess. So I'm going to close this up, if I can, and get back to our program. And Herb, I'm waiting for any questions you have. So someone asked me here, how long would treatment with the Edgelow method last? Kind of hard to say. Peter would often say it would be a 12-month program. Doesn't mean necessarily that it's always 12 months. Sometimes it can be less, sometimes it can be more. It probably goes back to the problem of how long has somebody had it, how irritable their symptoms are, how quickly can they progress the program, do they have secondary coexisting conditions that need to be treated. And so, 12 months would be sort of a ballpark. If a person is, but I would say 12 months, a person's still feeling better. If you were 50% better, that's a noticeable improvement. So I think a lot of people are looking at, just slowly, month by month, getting a little better, and getting back to doing normal things. Another question would be I've had TOS for 3 years. Would this treatment method take longer because I had the disease so long? I think it depends. I think it depends on again, sort of other conditions. It depends if you're still working or not. I mean, a person's still at work, we're more encouraged because they probably still have some function. But I would also say it takes a while for people to learn how to change their postural habits. It takes a while for the nerve entrapment to sort of open and calm down. So I still think that a year would be a reasonable plan. I don't think because it's 5 or 6 years, it's going to take double. But the sooner, the better. So the problem is with a lot of patients, they often see a lot of doctors and people before they find the right diagnosis. If they had found something sooner, I think we could have helped them sooner. I have another question here. What specialist should I see to help me with this diagnosis? My primary care doctor seems at a loss to help me. I think the problem is it's like where you're located. I think there's some places where there just aren't really, there's not a lot of knowledge about thoracic outlet or how to treat it. I think what we're trying to do is Scott has a website. I think the whole point is with that website is to get people who have the knowledge of the condition to kind of get them to connect with a practitioner that can help them. Sometimes that may be someone local. Sometimes they may have to travel somewhere. I think most people right now is with telehealth. I think we can discuss the problem at least by the phone or computer, and then go from there. A lot of what people tell me I've heard before, so I think it's you can help. Not that you can diagnose somebody on the by telehealth, but you can certainly help people find the right direction. I want to say that we're going to have some other talks on this, and part of what we're going to talk about is some treatment techniques without getting too specific. I've got a question here. Do all physical therapists use the Edgelow method? And are there methods that work well also? Peter's method, or Peter's was quite a, well, first of all, Peter didn't teach for probably 10, 12 years, obviously. So there are a lot of people that had taken his courses years ago, but like most things, if you don't use it, you lose it. So I would say that there probably are not a lot of therapists using the Edgelow method. Me being in the Bay Area, even here, it's difficult to find somebody who still remembers the program. Are there other techniques? I'm sure there are. I think anybody who respects, I think, this idea of not aggravating the condition, of working on posture, of working on kind of stress and breathing. I think all those techniques are not unique to Peter's program. I think there are techniques that a lot of people use, things like Feldenkrais and Pilates, work on movements that are not supposed to aggravate your pain. So I think people that use those techniques are effective. I would say there are some techniques like soft tissue myofascial release. I tend to think that those are more should be used in conjunction with kind of a physical therapy program. I don't think there's enough. Someone asked me, can they contact me directly? I live in Canada. Yes, I would contact us through the website. I'd be happy to talk to people individually. I think that'd be a better way. But I'd be happy to. I think the plan for us is that there are a lot of people in the country, in the world for that matter, that are probably not getting the right treatment, and that they might need to kind of reach out to us, and we can work with them in the best way we can. Hopefully at some point we start teaching the Edgelow method again and get people in the world to kind of still follow it. Is it an accredited program? Again, I mean, Peter developed a program. If you look online, there is a book called Thoracic Outlet Syndrome. It's I think it's put out like 2013, rather big book. Peter has several chapters in that book. It covers everything. It's very detailed, probably more for medical practitioners. A lot of parts about surgery, but you can read that book and see him in there, his program in there. as far as finding out who in your area would do it, there's no database, so people weren't registered. Again, my guess is the last time Peter taught that class was at least 10 years ago, and my guess is probably longer, actually. Peter retired probably 8 years ago. He was retired for 6 years before he passed. So we're looking at probably 10, 12 years. I'm not saying I'm the only one, but I probably have stuck closest to it, although that's not saying there aren't other people that do it. Yes, can things like a first rib mobilization help with opening up the tunnel? There is in the ENVEST program, in the Edgelow program, there is a rib mobilization exercises. There's a couple of them, and yes, rib mobilization can help people. I think that goes back to what I was talking about earlier about there's a program, but not every exercise helps every person. So I've had patients where we've done rib mobilization and it's made a significant change, and for other people, not so much. My guess is that because the entrapment may not be at the first rib, scalene triangle, it could be further down at the costoclavicular space or even the pec minor. So that's the think we're talking about earlier, I mentioned earlier, is where I think there's a trial and error here. So you try a first rib mobilization, see if it works. If that works, then we kind of keep going with it. If it doesn't work, we move on. So we're going to have a question here. I'm just reading this. I can't hear anybody. So Scott's going to ask a question, I believe.
Hey, Steve, that was great to see that all in one place, so nicely organized. What I found most interesting from the patients who you treat,
or maybe not,
is that they
we're
having a slight technical difficulty.
Let me talk a little bit more. I want to make clear that the ENVEST program is really a self-treatment program. When I look at myself as a therapist, my job is to educate the person, to show them things that they can do to have them understand their anatomy, understand what things work. What we also do is, I mentioned before about the objective measurements, things like range of motion, hand temperature, strength. There's a reason we look at that. It's objective as far as just supporting the diagnosis, but it's also, those are things that a patient can measure. So it's like really critical that a person sees that those things are important and that they're tied into their problem. And then as we're progressing their home program, we are using those objective measurements to show improvement. I like to say that most people will look better before they feel better, which means they'll see improvement in their range of motion, they'll see improvement in their strength. They may not feel better. Pain's kind of a hard thing initially to kind of control or even define, but you can see improvement objectively. And I think what that's showing is that we're starting to sort of take pressure or open up those tunnels. And then as those tunnels start to open, the nerve takes time to calm down. So I always make the argument, because I see patients that have surgery and they'll often remove the first rib and the scalene, middle and anterior scalene. They don't necessarily feel better right away. But the entrapment's gone. So why aren't they better? It's because that nerve's been irritated for so long that it takes time for that nerve to calm down. Now they can have better movement. Their neck, their shoulder, their strength can come back, but pain-wise, sometimes they're not better yet. And that just takes time. So I think when you're looking at a treatment program, you're looking for objective improvement first, not pain. Of course, we want pain to be better. We want function to be better, but it takes time, and that objective improvement supports your that you're doing the right thing. I believe we have a question coming up, but I'm still, I'll keep going. I can't, if you look at the Edgelow program, people ask me sometimes how often, oh, here, I'll go here. Patients often tell me they find good progress by learning about feedback. They learn how to become proactive at the first sign of exacerbation. I would say, let's go back to what I said about the objective findings. For example, in a lot of cases, not all of them, hand temperature is an indicator. So a person starts to work at their computer and all of a sudden their hand gets colder. Maybe their pinky. But most people dismiss it, blow it off. As they keep going, then all of a sudden their arm starts feeling more numb, and then their pain in their shoulder or neck gets worse. But it could be that that hand temperature coldness was one of the first signs that things were getting worse. So it goes back to, let's say your hand starts to get colder. Let's say you stop. I'm going to say that you can do this. Let's say you start. We have some exercises that I might give you. It's a breathing exercise, for example. It might even just be changing your posture. All of a sudden, your hand starts getting warmer again. That's your biofeedback. That's an indication that something happened, but also you did something and something changed. So if you're talking, so that's the biofeedback that I'm talking about. There is biofeedback, and there's electrodes and muscle biofeedback. I don't do that, but there are people that do it, and it could be effective. I don't know how they could really measure the scalenes or the pec minor. A lot of times they measure like the upper trap and trying to see if a person's shrugging their shoulders or leaning forward. There are some biofeedback devices that are on the market now that kind of give you feedback on your posture. I'm sure all those things are helpful. If I can talk a little bit about the Edgelow program, people ask like, well, how much time do I need to spend at it on a day? It depends. If you look at sort of the classic sort of formula, you tell people to do their exercises 4 times a day. That might be 10 minutes, 15 minutes, 20 minutes. Kind of depends on whether you're working or not. And also to walk up to an hour and 20 minutes a day. Again, this all depends on how busy you are, how aggravated your symptoms are, but you're trying to do something throughout the day to kind of counterbalance the effects of the things that are probably aggravating it. I think the general feeling is 24 hours a day, you're either helping it or you're hurting it. Or you can also say I'm neutral, which is also a good thing. So I would say is that, but we know for sure that the program is developed that if you're doing 20 minutes of breathing or exercises, that you know after that 20 minutes, it's helpful. So we're pretty sure that that hour and 20 minutes of exercise is always going to help, and that could counteract some of the problems of just working and sitting. So I said, do you have any recommendations for TOS breathing techniques? Yeah, the breathing techniques are a big part of the program. To simplify it, we're mostly doing diaphragm breathing, or we are doing diaphragm breathing. We're using the diaphragm and the intercostal muscles. Those are your primary breathing muscles. So when a person is doing diaphragm breathing, they usually need to be in a position that allows for diaphragm breathing. It goes back to what the posture part is. So if the person's slouched, you really can't do diaphragm breathing. So a lot of times when people are asking as we're sitting, how do I keep my posture better? A lot of times I'll say, rather than just thinking about your posture, I'll say, think about your breathing. if you think about your breathing, and you have to breathe from your diaphragm in a way that kind of almost corrects your posture, because in order to breathe from the diaphragm, you have to correct your posture. Also, breathing is a way of sort of being in the moment, taking kind of a survey of how you're sitting, how you're feeling, whether you need to take a break, are you stressed? So breathing is an important part of the program, and it's the first day I see somebody, that's what we teach, breathing, because the breathing becomes part of every exercise we do, whether it's the first group of exercises, whether we're doing a ball, foam roller, and later on, if we get to strengthening, we're still talking about breathing. I would say, someone said, I think this is the same question, do you have recommendations for TOS breathing, or is it specialized for each patient based on clinical evaluation? I mean, everything is based on clinical evaluation and patient specific, but I would say everybody gets some sort of breathing technique in program exercises. Some people may not be able to breathe as deep. There are some parts of the program which involves the sort of pelvic tilts and movement, and sometimes people can't tolerate that, or we have to sort of we have to modify it. But I would say breathing is always a part of each treatment or the program, and it's involved in every exercise of the program. I'm not sure if there's any more questions. Oh, there's somebody, he had a parent from California, wanted to say, you really helped my daughter. We do see, I do see a fair number of younger folks, usually athletes, who have thoracic outlet. And it's actually quite satisfying to sort of help somebody not just get better, because I mean, a lot of people just want to feel better, but to actually get back and to do what they want to do, whether it's swimming or playing sports, music. The goal for the treatment is for people to get back to doing what they're doing. It's to get back to work. It's to getting back to exercising. It's to getting back to having a life. And I think that can happen. But it takes time, and it takes having the right people on your side. And I'm not just talking about me, but I'm talking about having support from your doctor, from the people that are sort of just covering your treatment. Have you ever come across a person that you had to tell them to stop treatment? I never tell someone to stop treatment. I think there's things within treatment that you would stop. I think a lot of people are, especially people that I've seen that have gone through a number of different practitioners, a lot of times they have a mix of exercises. So they're doing core exercises, or trying to. They're doing yoga, they're doing other things that might be aggravating their condition. I think within the Edgelow program, same thing. You only progress to a new exercise if that exercise doesn't aggravate you. So if we're stuck, you may need to sort of stay where you are and do the exercises that you've been doing up to that point, not progress. If you've done the whole program, but you have a flare-up, you may need to go back and do the beginning exercises until things calm down. So every day is a little bit different. I tell people, if you have a bad day, you focus on your breathing, your relaxation exercises, you do some walking, you just kind of calm things down. If you're feeling better, we can work on thoracic mobilization, we work on core exercises, could even start to work on scapular strengthening later on. because at that point, if that doesn't aggravate you, that's the next step. But if things are aggravating you, you got to calm down. It's not, as I said earlier, it's not a no pain, no gain program. But it is a program where improvement is expected. Day one, I expect the first day to see you, for the first day that you start the program, to feel a little better, even if it's been 5 years. Because again, it's because I think we're treating the right place. The reason people aren't getting better is because they're not getting the right treatment, or you're getting a treatment in an area that's either not the main problem, or that treatment is aggravating their thoracic outlet syndrome. So if you have somebody who has TOS and a neck injury, and they're doing exercises to strengthen their neck, but by doing that, they're using their scalene muscles or using their pec minor muscle, and they're causing more compression in that area, those exercises are going to make it worse. So, so we have to look at that. And what I'm hoping is that people would use those subjective or those objective measurements and temperature, range of motion, strength, to see if a particular exercise is making them worse, and then to go from there. Okay, so we're going to wrap it up. There is an upcoming event on October 6th. We have Tracy Newkirk. It's called The Language of Thoracic Outlet Syndrome. Tracy Newkirk is a neurologist, specialist in thoracic outlet. There's no one like him. He's sort of like Peter was. It's that he has a ton of experience, a lot of knowledge. He's supportive, knows his stuff, is doing some great things with some vests and other supports. And I think he'd be a great person to listen to. I don't know if you have anything else here, but thank you for joining. And again, feel free to contact the website if you need to contact me or somebody else in the program. And I really appreciate you guys taking the time to listen to me. This is not my specialty, talking before people, so I hope it wasn't too bad. I'm going to be doing another one in a month or so, I believe, hopefully, and we'll go from there and see how that goes. Thanks again.